And so the nephron is kind of the functional piece. This is where all the magic is happening in the kidney itself, right? This is basically where you're making urine. And so we talked a little bit about the beginnings of it, right? The capsule wraps around the glomerulus and then the proximal convoluted tubule. And now from the proximal convoluted tubule, we enter into what's called the loop of Henle, or the nephron loop. And so the loop itself has not an actual loop like a circular loop, it's just more like a little horseshoe turn. And so it has two different sides of it. It has a descending limb and it has an ascending limb. And the permeabilities of these two limbs is different from each other to water and solutes. And then from the loop itself, you'll move into the distal convoluted tubule. And the function of the distal convoluted tubule is typically to exchange ions and sort of the last little bits and pieces of stuff that you want to add to the urine stream if you want to get rid of it. And this is your last chance to pull something out of that urine stream if you want to reclaim something. And then from the distal convoluted tubule, it's going to be moving into the collecting duct. And then that will basically drain the urine into the renal pelvis. So you go from the glomerular capsule to the convoluted tubules, and these are all basically in the cortex of the kidney itself. The loop then will dip down into the medulla, into the medullary area, and then that'll come back up to the cortex. So if you have the kind of cortical and medullary breakdown, so here's the cortex, here's the medulla, your capsule and the proximal convoluted tubule will be up here in the cortex. And then your loop will dip down into the medulla, and then it'll come back up here to the distal convoluted tubule, where you'll have the collecting duct basically that kind of goes down. So this is your capsule, this is your PCT, this is your loop, this is your DCT, and this is your collecting duct as it heads down to the tip of that renal pyramid. And then at the base of the medulla, you'll have the collection of the urine in that calyx system as it drains into the renal pelvis itself. So let's take a look at how we actually make urine. And this is going to basically allow us to be able to walk through the parts of the nephron, because you can't really talk a little functionally about making urine unless you're actually going through the parts of the nephron itself. And so there's three main regions or phases of urine production. The first one is filtration. We already talked a little bit about that sort of filtration, that slit-like filtration membrane that occurs between the capillary-like glomerulus and the Bowman's capsule. And then from there, as it goes through the tubular system, you have what's called tubular reabsorption. So this is the take back, right? So basically you got a bunch of stuff now in your filtrate and you want to take some of that back. So this is the take back piece. You're reabsorbing it into your blood system by way of those peritubular capillaries. And then you have tubular secretion, which is the give up, right? So this is the stuff you're adding to the filtrate to be urinated out. You're getting rid of it, right? And so it's those three pieces. And so when you kind of take a look at a recapitulation of our nephron, we're basically going to be starting off in filtration, basically in the glomerulus. And so when you take a look at filtration, the blood is going to be going into the glomerulus by way of the afferent arteriole, right? That's the inlet. Now, remember, we talked about this a little bit before, but remember the afferent arteriole has a larger diameter than does the efferent, which basically means that you have an increase or a high glomerular blood pressure. And so this blood pressure that's inside the glomerulus will basically force fluids out of the glomerulus. So basically this pushes fluid against the filtration membrane. Very similar to like, like Play-Doh, right? That's one thing I always remember is sort of the Play-Doh spaghetti. You kind of put the Play-Doh in kind of that press, and then it kind of pushes it through those little holes, and you kind of get the little strings of Play-Doh spaghetti coming out. That push, that force, it's pushing it against that filter. That's kind of what's happening here with the blood pressure. It's pushing it against the sieve-like filter of your filtration membrane. Now then, the fluid that enters or that basically exits the glomerulus is what's called the filtrate, right? And this is basically the fluid that's inside that capsule, inside the glomerular capsule. Now, at this particular point, the filtrate resembles plasma. So basically, you have your glomerular capsule, and then you have your glomerulus. And so you're pushing all of that fluid into this little glomerular capsule. And that's what's in this capsular space, is the fluid, that filtrate. And so you have a lot of different things. For instance, going against this filtration membrane, you can get out a lot of fluid, but the big stuff can't go. Like, for instance, all those formed elements, red blood cells, white blood cells can't go through because they're simply too big. And so when you take a look in the glomerulus itself, you can technically break blood down into either filterable components, that typically means they're small, they'll scooch through that filtration membrane, or they're non-filterable, which basically means they're too big. Like, for instance, big, large plasma proteins, for instance, are just too big to fit through those little tiny pore sizes of your filtration membrane. And so the filterable components that we typically will get in the filtrate, so these basically make it into the filtrate, are things like water, certainly, right? The different nitrogenous waste, we talked a little bit about that already, right? So all those nitrogen containing compounds, ammonium, urea, things like that, those are small enough to scooch through. Small nutrients and salts, ions, things, for instance, like sodium and things of that nature. So those will basically be able to fit through and filter their way through the sieve. Things that won't get through are the big stuff, right? So these guys are big. So blood cells, for instance, are too big. Platelets are too big. Plasma proteins are too big. So they're left behind in the blood. And so they'll stay in the glomerular blood system, and then they'll exit the glomerulus through the efferent arteriole. And so ultimately, the filtrate looks very similar to the plasma. Now, this is not what it's going to look like once you get ready to flush it, right? Once you get ready to flush it, your filtrate looks very different. That's because you're adding to and taking away through this reabsorption and secretion process. And so that's something that's constantly going on in this particular system. Now, if you take a look at some of the filtration, water, for instance, on about a daily basis per day, you're filtering, that is to say, you're moving into the filtrate stage about 180 liters of fluid a day, right? That's a lot. A liter is roughly about a quart. It's about a fourth of a gallon, okay? So the amount that you're excreting is basically a hundredth of that. So you're only maybe at about half a gallon, roughly, of excreted, which means you're absorbing the rest. You're taking it all back, and you're putting it all back into your system, right? So that's kind of the idea, is you don't do the selection up front. What you do is you basically dump everything in the middle of the room, and then you do the selection on the back end. So you kind of sort through everything, and you sort of start picking and choosing the things you want to keep and the things you want to get rid of. For sodium, right, so this is basically your Na+, you're filtering about 630 grams a day. You're only excreting about 3.2, which means you have north of 99% retention or reabsorption of that. Glucose, you filter out about 180, the same as water, but here you're not excreting out any of it. So you get 100% reclamation. You're going to reclaim all of your glucose, which makes a lot of sense, right? Think about it. Glucose is your food. You had to work hard to get that food. Like, if you're a mammal, you had to chase down that prey, and you had to do a lot of work to get that food. You're not just going to urinate it away, right? So you're going to hang on to that. And then, of course, urea. Now, urea is different, right? Because we urinate out a lot of urea, but we also retain a lot of it, right? So there's about roughly 54 grams of urea that we actually get into the filtrate. We only excrete about 44% of that. The rest of it we typically use to help balance the osmotic conditions that are happening inside our tubular system. Okay, so urea is actually kind of helpful for us. So let's take a look at the tubular reabsorption, right? So we just talked about filtration. Now we want to take a look at tubular reabsorption. And so this is basically where molecules are taken back and they're moved back into the body by way of this peritubular capillary network, which we saw before earlier in the chapter, right? And so typically when we have a molecule that happens to be in the filtrate and we want to bring it back in, we can either move it in passively, right? Like passive transport, like channels, ion channels and things like that, or we can do it actively. We're going to actually actively pump it in, which is going to require ATP. So sodium is going to be reabsorbed at multiple localities in the body. So it can be actively transported in a couple of ways. Number one is as a symporter. A symporter is essentially a transporter that will bring two molecules in the same direction. So they're basically moving in the same direction. If it's active transport, they're both going against their concentration gradient, right? So this is basically how we can move larger solutes like amino acids and glucose and things like that. Antiporting, this is basically going to be moving a sodium into the cell while usually taking a hydrogen ion and moving it out. It's an exchange. I'll swap you a hydrogen ion because we're a little too acidic for a sodium, right? And sodium is also always useful. And this is basically one of the ways that we can regulate pH, right? So an antiporter basically is kind of a similar idea. In this particular case, what's happening is one molecule is moving one way while the other molecule is moving the opposite direction. That's antiport. Okay. So you bring sodium in while a hydrogen ion goes out, and then that out basically means into the filtrate. That's your urine, will become your urine. So you're basically dumping the hydrogen ion into your urine stream. That basically regulates the acidity of your blood. However, sodium can also be moved around passively as well. And so generally speaking, when you're moving sodium around, the one thing you need to remember is that you're not just moving sodium, you're also moving charge, right? And so we don't want to move charge because that will create this sort of electrostatic buildup, very similar to like static electricity or like lightning. And so oftentimes when you move a sodium or a positive charge, a chloride will move along with it in order to sort of balance out that charge, basically neutralizing the charge. And that's kind of where you get your total salt complement. So the reason why you have sodium chloride is because the chloride is there to balance out the sodium, to make sure you don't get a lot of charge buildup. And so ultimately, in the end, you end up getting the reabsorption of both sodium and chloride. And so this will basically be increase in the saltiness of your blood itself. Now, once you do this and the sodium chloride moves into the bloodstream, now what you've done is you created this osmotic tension that allows water to passively move from the tubular system into the blood. Why? By the osmotic sucking effect of the sodium chloride. Remember, salt sucks. That's our mantra, right? So if the salt moves into the bloodstream, that means the water chases after it out of the urine stream and back into your body. This is how you reclaim water. Generally speaking, almost 2/3 of your sodium ions are basically reabsorbed in the proximal convoluted tubule. So as soon as your filtrate enters the tubular system, you're at work bringing that all back in. So nutrients, for instance, like glucose and amino acids, typically these guys are going to be reabsorbed immediately as well. They're also coming in the proximal convoluted tubule. Normally, glucose completely comes in, and it's usually transported in by active transport with these carrier proteins. Okay, so like I said, you don't want to lose your glucose. That's precious nutrients. This is also one of the reasons why, if you have a lot of glucose in your urine, that usually means that you have an extremely high blood glucose level. That usually means you're diabetic, right? That's kind of where diabetes mellitus comes from. So this is basically when you have a blood glucose level that's really high, way above normal. And what happens is you just have so much glucose that you just start shedding it. You start getting rid of it, and that's when it starts to show up in the urine. So it only happens under very, very abnormal conditions. And the reason why is because you've got so much glucose in your bloodstream that those glucose transporters that are responsible for bringing the glucose back into the body, pulling it out of the filtration stream, they get saturated. So they're overwhelmed. They're saturated. They're busy. So the excess glucose gets eliminated. So you don't have any extra room. All your transporters are full. So, it's sold out. Any extra glucose basically just moves into the filtrate, and then that's when you can test it in your urine stream. So ultimately, when you have a ton of glucose in your filtrate, what this does creates the solute concentration in your filtrate. So basically the osmolarity or the solute concentration, which creates a strong osmotic tension. So basically your urine becomes like salt, right? It's like salt. It's not salty, but solute. It's got a lot of dissolved components in there, which are have a sucking effect on water. And so ultimately what happens is this will basically cause water to move into the filtrate to try to dilute that. And then that basically forces you to eliminate liquids and fluids more frequently, which is the reason why you get frequent urination. And since your water is moving out because it's seeing all this glucose in there that it tries to that it chases, then you start losing a lot of water, and you can start triggering your thirst response, which is oftentimes one of the symptoms for uncontrolled diabetes. Is you basically have sticky urine, and you have this kind of unquenchable thirst because you're urinating out all your glucose, and a lot of that water is going back into it. Now, what about secretion? So secretion, remember, is the stuff that you're giving up. So ultimately, the main bulk of the molecules that are moving into the filtrate is through filtration, right? The first is filtration. That's the first step. But you can add more along the way. So that's secretion. For instance, if you dump hydrogen ion into the tubular system to the filtrate, that would be secretion of the hydrogen ion. Creatinine as well, drugs like penicillin are secreted or dumped into the filtrate. And so these are basically things you're just dumping into the filtrate for elimination to get rid of them. And so urine ultimately will contain a couple of things. First of all, stuff that's been initially filtered out through the filtration system at the very beginning of the nephron. It'll also have stuff that's been secreted along the way, extra things that you've dumped into the urine stream that you want to get rid of. Okay. But one thing it will not have in it is the stuff that you reabsorbed, like glucose, for instance. Okay. And so that's basically what your urine is composed of. Now let's go ahead and take a look at some homeostasis. So when you take a look at the kidneys and homeostasis, you can see that essentially the urinary system kind of touches just about everywhere. Right. So, for instance, when you take a look at the cardiovascular system, here you're basically looking at regulating blood pressure. So you're maintaining blood pressure. So that's an interaction with the cardiovascular system. For the digestive system, absorption of ions, for instance, calcium is happening in the digestive system. For the muscular system, you need ions in order to contract your muscles. Like sodium, for instance, is the basis of your action potential. It's the way your nerves actually send impulses that go to the muscular system for contraction. So if you don't have sodium in your system as your kidneys take it up, then you're not going to have the fundamental ion you need in order for your nervous system to work. The respiratory system is important because it's regulating the acid-base balance, right? And so is the kidneys. They're also regulating the acid-base balance of your system. The endocrine system is important, right? Because you got all kinds of hormones that are governing and working on the salt-water balance, for instance, is tied to the endocrine system. Calcitriol is technically a hormone that is associated with calcium absorption. ADH is part of blood pressure regulation. Then, of course, the sweat glands, which is a type of excretion system, is getting rid of excess water and salts and a little bit of urea. So you can see how basically the urinary system is kind of tied into just about every other system. So as the liver basically produces urea, the muscles are making creatinine when they do their anaerobic respiration. And all the body cells will make uric acids as they metabolize nucleic acids. And so ultimately, these will be taken by the cardiovascular system to the kidneys for screening. The sweat glands will be getting rid of a mixture of salt and water and urea. And so they're all kind of combined together to basically get rid of a lot of these different compounds. If you have kidney failure, ultimately what's going to happen is you're going to have a buildup of urea because it's not being gotten rid of through the kidneys. And so you'll have a buildup of urea in your sweat. And you'll create a lot of times what's called uremic frost, which is kind of like it's almost like like hoarfrost. If you've ever kind of seen that light, fluffy kind of frost, it kind of is a white deposit of precipitation of urea on the skin. And so sometimes you can see that in cases of extreme urea imbalance. The water balance mechanism. This is obviously part of what the kidney does for a living. And so the filtrate that's reabsorbed will allow you to concentrate the urine if you're reabsorbing a lot of water. So different parts of the nephron loop, like the collecting duct, for instance, and the actual loop itself, will actually focus on reabsorbing water. Remember, a lot of the important stuff is absorbed right up front in the PCT. And so the loop and the DCT are often focused on water retention. So you're bringing water back in. And so before you do that, however, you have to have some sort of an osmotic lure, which basically means that you have to reabsorb salt first, right? Because remember, salt sucks. The way you get water to come out of your filtrate is by creating a salt pile that the water wants to chase, which means you have to bring the salt into your blood system first, and then the water will chase it back into your body and you retain the water. So you always start off by manipulating salt first, and then the water will follow. And so ultimately, when you do this, the water will basically move wherever you want it to move based on where you put your salt piles by osmosis. And then they'll move freely back and forth, responding to those salt concentrations through open channels called aquaporins. Those are the special channels that are specific for water movement into and out of cells. So then when you take a look at the sodium ion, we said that about 99% of that is reabsorbed, right? So you reabsorb 99% of that that's filtered in the glomerulus. And so the kidneys then will kind of reclaim most of that sodium ion and thereby reclaiming most of the water as well. So you can concentrate your urine actually considerably by using this technique. However, you also reabsorb, you grab onto and bring into other ions as well, right? For instance, if you take a look at potassium, you also bring in potassium, bicarb ions, you'll bring in also magnesium. So these are other ions as well that are being reabsorbed by the kidneys and brought back into your body. And potassium is important because it works along with sodium in your nervous system. And so it's a necessary ion for your nervous system itself. So then ultimately, when you take a look at the cortical regions, that is the DCT typically, is what we're talking about here. About 2/3 of the water that is in the glomerulus is reabsorbed back at the proximal convoluted tubule. So generally what happens is in sequence, you will actively reabsorb sodium, right? That's your salt. Chloride will passively follow to balance out the charge. So that basically creates your salt concentration. And the aquaporins are always open, right? So basically, as soon as water sees the salt pile building up in your bloodstream, then the water will automatically chase after that salt concentration and into the bloodstream it goes. So you just basically retained all of your water. Now, there are some hormones that regulate this. that will allow you to be able to manage, especially the reabsorption of sodium, right? So for instance, aldosterone, which we talked a little bit about before, is going to be the main hormone. It's secreted by the adrenal glands. And this will basically allow you to retain sodium. And then, of course, by allowing you to retain sodium, so typically potassium is excreted, the sodium is reabsorbed back into the blood. And then what happens is that allows water to come in and chase it, right? So aldosterone increases that sodium retention, which sets up the osmotics backdrop for water to be able to move into the bloodstream. And so the aldosterone release itself is actually triggered by the kidneys, right? So that's an important endocrine function of the kidneys itself. Now, where you sense all of this is a particular region called the juxtaglomerular apparatus. And so what happens here is typically right behind the glomerulus. So you see the inlet to the glomerulus, you see the afferent arteriole coming in. And so all the blood is kind of going through all of these little slits, these sieve-like slits, and all that filtrate is going into the capsule, getting ready to move to the tubular system. And then the leftover blood is coming out of the efferent arteriole. Smacked up in that, wedged in that little corner is a group of cells and the distal convoluted tubule. So what happens is the distal convoluted tubule is actually kind of bent backwards. So normally we kind of write it out linearly. So basically what happens is your afferent arteriole comes in to the glomerulus, your efferent arteriole comes out. And so here's your capsule. And you have your proximal convoluted tubule, your loop of Henle. And then what happens is the actual distal convoluted tubule bends back and then kind of goes in front of that capsule. So this is your DCT here, this is your PCT, and this is your loop. And so that DCT piece is going to be the area that's blown up here. Okay, so it kind of bends back behind that glomerulus. And what it does is as it passes by, you can see that it kind of captures or entraps a wedge of cells in between those three. So between the afferent, efferent, and the DCT, there's a wedge of cells in there. And so there is a couple of groups of cells. There's actually this whole region right in here is the juxtaglomerular apparatus. And then half of these cells, these guys right here, are what's called the juxtaglomerular cells. And what these guys do is these guys sense blood pressure drops. That's basically what these cells do. Now, there is a group of cells that is part of the distal convoluted tubule that are kind of condensed and sort of smashed up. This is the second piece of the apparatus. These are called the macula densa cells. And these guys basically will sense sodium changes. So between the two of them, you basically have your finger on the pulse of two major pieces of blood pressure, right? Number one is blood is mostly water. So blood pressure and water pressure are simply synonymous. And so the JG cells are responsible for measuring those blood pressure changes. Why does blood pressure change? Because of the osmotic change, right? So that basically means salt is going to be changing the amount of water that you're seeing. So you have a sensation for the amount of sodium. The idea being that if you have too much sodium, you're going to have too much blood pressure because you have too much water. That increases your blood volume. And so you have kind of a measure of both components, not just the amount of water, but also the amount of salt that's causing the amount of water, right? And so that's basically where your sensation comes in. And so ultimately when your blood volume, which is essentially synonymous with blood pressure, why? Because blood is mostly water. Then what happens is the juxtaglomerular cells will secrete renin. And renin is an enzyme that will basically go through the angiotensin groups. I think we mentioned that before on a previous slide. The angiotensins will basically be converted and will convert into aldosterone, will stimulate aldosterone production by the adrenal glands. And this will then create the effects of aldosterone, which is retention of sodium, which then allows you to retain water. So you can see it's like a big chain reaction, okay? So your low blood pressure, okay, I'm going to put it all together here, will basically be sensed by the JG cells. And the JG cells will basically secrete renin, which will turn angiotensinogen into angiotensin 1. So that's what renin does. And then angiotensin 1 will go to the lungs and be converted by an enzyme called the angiotensin converting enzyme into angiotensin 2. And angiotensin 2 will basically stimulate aldosterone production, which will stimulate sodium retention, which will stimulate water reabsorption. When you absorb water, it'll increase your blood pressure. So that's basically your homeostatic cycle. That's what's happening all the time, by the way. Right? This isn't just something that happens every now and then. Your blood pressure is constantly going up and down and up and down in its homeostatic norm. And typically this system, this renin, angiotensin, aldosterone system is what's causing that rise and fall and rise and fall. Okay. So antidiuretic hormone is also a player in this one. I didn't put him down there. But ultimately what allows for water reabsorption is ADH. And so ADH is actually a hormone that is typically active in the distal convoluted tubule. Normally in the distal convoluted tubule, you can't reabsorb water. It's impermeable to water. And so if you produce ADH, it's usually produced by the hypothalamus, and it's secreted by the posterior. So what happens is the hypothalamus makes it, it stores it in the posterior pituitary, and then the posterior pituitary releases it in situations where you have low blood pressure. And so what this then does is it permits the water to move from the distal convoluted tubule and the collecting duct that's active in both areas back into the bloodstream. So this basically creates access for the water. And so you constantly are making ADH. It's constantly part of the system, right? So basically, if you're wondering, everything we've talked about, basically from these slides, 56 down to 59, we're all basically looking at the blood pressure homeostatic curve, where you basically have a peak and a trough and a peak and a trough and a peak and a trough and a peak and a trough. And so what's at the base of it is this RAS, what I call the RAS system, right? This renin, angiotensin, aldosterone, ADH system. Okay, that's involved in increasing the blood pressure, getting it back up. But what happens if you're at the peak? If you're at the peak, then this is going to be the next one. This is going to be the ANP-BMP system. It's a peak reflex. So ANH or ANP, atrial natriuretic peptide or hormone, you can see it in two different ways in different books. This is basically a hormone that's going to be secreted by the atria of the heart. And so ultimately, when you have an increased blood volume, that basically means high blood pressure. That's where our peak is, right? So that's basically where we are. We're at our peak. We have high blood pressure. It's going to be felt and sensed by the amount of stretch in your atria, right? Because after all, your blood volume goes through your heart. The first chamber it goes into is the right atrium. And so your right atrium is the first one to feel this abnormal stretch, right, of all this excess fluid, this excess blood volume in there. And so that amount of stretch will basically trigger this ANH response. And so this will shut down the secretion of renin. It'll inhibit that. And by that, it'll also shut down aldosterone. And it basically promotes what's called natriuresis, which is the excretion of sodium. The idea is if you excrete sodium, water will follow. And where's that? In your urine, right? So your sodium gets dumped into the urine to get rid of the excess sodium, and then the water will chase that sodium into your urine stream. And then that's basically what's happening. So it basically will allow the water excretion by way of letting water chase it into the filtrate so that you can flush it. So you get a more dilute urine itself. So what about the medullary? So those are, we're talking about the distal convoluted tubule there, right? And so that's basically water and salt reabsorption associated with the cortical region, because that's where the proximal convoluted tubule and the distal convoluted tubule are found. But what about the loop, right? So that dips way down into the medullary region. So how does that work exactly? So the loop, essentially, the loop of Henle or the nephron loop, remember it's made of a descending and an ascending limb. In the ascending limb, typically, salt, sodium chloride, will passively diffuse out of that lower limb into the surrounding tissues. So the concentration of that salt becomes greater the deeper into the medullary area you get. And that's an important thing. It's what I refer to as an osmotic ladder. We'll see a picture of that here in just a second. So the descending limb, the one that's coming down, is permeable to water. And so this allows water essentially along its entire length to exit the descending limb and to basically remove itself back into the bloodstream. And the reason why it does this is because of this osmotic gradient that's inside the medulla, the so-called osmotic ladder. So as fluid goes from the proximal convoluted tubule into the descending limb, what happens is the fluid increases or experiences this salt concentration that basically gradually continues to increase. Now, using the principle of osmosis, salt sucks. That means if it's salty on the outside, not so much on the inside, that means that the salty outside is going to pull the water out, right? It's going to suck the water out, and that's what happens. So the water will exit because in response to the sucking effect. And that's because it's permeable to water. Now, the ascending limb is not, right? So basically, it doesn't have any aquaporin, so it's non-permeable to water. So it doesn't allow water to leave. And so it has a different job. The descending side is basically to suck water out of the filtrate back into your body. And you're using salt concentrations to do that. The ascending side is essentially to create that salt concentration. You're creating that gradient. And so ultimately it looks something like this. So here you can see your loop system. So basically as you go down the descending side, remember it's permeable to water. And so if you take a look at the concentrations of salt, so it's more concentrated as you get down to the bottom. What happens is you kind of have this strata. So you basically have 300 milliosmoles, which is just a measure of the saltiness of that particular area. A milliosmol can be seen as a unit of saltiness, like an osmotic tension. So it goes from 300 to 600 milliosmoles, so it's a little bit more salty, to 900 milliosmoles, right? So it's a little more salty, and ultimately up to 1200 milliosmoles. And the idea is because it's saltier on the outside and the inside, it's going to suck the water out into this tissue as it continues to go down. So it's like progressively, successively sucking the water out, stronger and stronger and stronger as it gets down to the bottom of the loop. Then this little black outline is showing you the impermeability to water. So what happens is the water kind of rounds the bend, so the water can't leave anymore. But what happens is essentially you have sodium chloride pumps that pump sodium chloride back into that system. So you're pumping out the system, and the sodium chloride being pumped out into the medulla is what creates the salty ladder. Right now, the reason why it's laddered like this, 3 to 600 to 900 to 1200, is because the pumps that are down here lower are faster than the ones that are up higher. Therefore, they're creating a saltier buildup at the bottom as opposed to at the top. So the effect of this is essentially to suck all that water back out, and then eventually what's going to happen is it's going to go back into your bloodstream. So this is a major, major area of water retention in the body. By the way, in the collecting duct, it's happening the same way, right? So the same salt concentration gradient is sucking water out of the collecting duct. So it's coming out in a couple of different areas as well. So in the collecting duct, basically, you get the same osmotic gradient as the descending limb. This was created by the ascending limb. And so the water will move out of the collecting duct into the tissue and then be basically mopped up by the blood capillaries. And this is only in response to ADH. Without ADH, it's impermeable. The collecting duct is impermeable to water. So you have to have ADH in there. So diuresis basically is a situation where you have an increased amount of urine. So essentially a dilute urine, right? And antidiuresis is when you have a decreased urine, so you have a concentrated urine. So for instance, if you take a diuretic, so what that's doing is creating more water loss in your urine. And so that's reducing blood volume, which reduces blood sugar. So a lot of times, blood volume, blood pressure, right? So basically, a lot of times what happens is if you have high blood pressure issues, a lot of times you'll take an antidiuretic, right? Or excuse me, a diuretic, right? And then that'll basically dump more of the fluid into the urine stream, bringing your blood volume down, bringing your blood pressure down. An antidiuretic is kind of like the opposite. So essentially that's facilitating the opposite direction. So for instance, coffee, caffeine specifically, not coffee in general, but caffeine specifically, is actually a potent diuretic. So for coffee drinkers who like to drink lots of coffee, oftentimes you will have to urinate more often, because the caffeine is stimulating diuresis, which means you're increasing the amount of urine. As a matter of fact, if you want to do a double whammy, drink coffee and lots of water at the same time, and I guarantee you, you will never leave the bathroom, right? Because you have a diuretic in conjunction with a lot of volume of water that you have to get rid of. So in this particular area then, ADH will essentially increase your water reabsorption. And because you're reabsorbing more of your water, you're decreasing the amount of volume of urine. So you're basically urinating out a more concentrated urine because you're reclaiming all the fluids through ADH. So the ANH then, which we kind of talked about a little bit already, is essentially something that's going to be triggered when that's a typo. It's not ANH because it's ADH. Because ANH is not low blood pressure, it's high blood pressure. Where we just talked about ANH. Basically, ANH stimulates the dumping of sodium and the loss of water to reduce blood volume and blood pressure. So it's a high blood pressure response, not a low blood pressure response. A low blood pressure response is ADH. So ultimately, when you have decreased sodium levels in the blood, this can be caused by several problems, like if you're letting go of a lot of fluids through sweating, things of that nature, that can cause a decrease in sodium. That's one of the reasons why a lot of athletes have electrolyte drinks. Gatorade was the original. is to replace some of that sodium. When your blood pressure falls, you're going to start triggering that renin-aldosterone sequence as well. And then the kidneys will basically reabsorb sodium, causing the water to come back in. So if you're very dehydrated, you're going to basically be urinating out a very small volume of highly concentrated urine, okay, because you're hanging on to most of your water. So ultimately then what's going to happen is the osmolarity of your blood is going to return back to normal. Your water is going to come back into your blood, increasing your blood pressure, which gets your blood pressure back to homeostatic levels. So for instance, when you take a look at a marathon runner who's running 26 miles, right? So it's long-term endurance types of exercise. You don't want to drink pure water, right? Because pure water is too dilute. And so you don't want to dilute your sodium ions. That'll sort of mess up your osmotic balance, which can cause problems. That's the reason why you have more of a kind of an electrolyte mix, is to sort of keep that balance. So the sports drinks will have the sodium and the water in it. The problem with them is not so much the electrolytes that are in them as much as it is the sugar that's in them, right? So for instance, they'll have lots of calories in them. And so generally speaking, if you're under like 90 minutes of exercise, typically you should be looking somewhere else, right? So Gatorade is typically something where you are supplementing for like 90 minutes or more. So that's like an hour and a half. So if you're working out for an hour and a half, then that basically means you're doing something long-term and something that's kind of in like an endurance sort of a thing. And that's kind of where that comes in. So the sodium chloride basically from food, you can absorb that from food as well. So this is another place where you can get it from. So you can retain it or you can absorb it from your food. And we have typically no shortage of sodium in the food itself. And so if the sodium comes in through the food, then the blood level will increase above normal. And so when this happens, then this will become the ANH response, right? So before, low blood pressure was the ADH and high blood pressure is the ANH. ADH brings low pressure up. ANH brings high blood pressure down. That makes sense? So if you have a high amount of sodium in your bloodstream, then what that means is a lot of water is going to come into your bloodstream, increasing your blood volume and the amount of stretch in your atria. That's going to trigger the secretion and the release of ANH, the atrial natriuretic peptide, by the heart, and that's going to shut down sodium and water reabsorption. And then the blood volume is going to decrease, bringing that back down. And then you're going to dump sodium and water into your urine stream to get rid of that excess blood volume. So basically, the two of those, ADH on the trough response, what I call a trough response in homeostasis, and ANH as the peak response. Okay. So diuretics, basically, we've already mentioned, they've increased the urine flow by increasing the volume. Alcohol can increase diuresis by shutting down ADH, so they can inhibit ADH, which basically means you're not going to be able to allow the uptake of water. And so that means you eliminate that water. Caffeine is a potent diuretic. We talked about that one already. Different types of drugs for high blood pressure are natural diuretics. These will basically allow you to excrete the extra blood volume to keep your blood pressure down. So then we come to the function of the urinary system for the purpose of regulating the acid-base balance of your body fluids. So remember, your normal blood pH is kind of like right around, on average, 7.4, and you have to maintain that. So ultimately, This is where a lot of our proteins are working. Our enzymes are maximally functional in this particular range. If we begin to become too acidic, and notice it's not a lot. I mean, if you're a little bit below 7.35, you start to get acidic, and we refer to that as acidosis. It's the acidification of your blood. Now, if you start to sail above 7.45, notice it's not a big swing, then that's alkalosis. This is the alkalinization of the blood. And so because it's constantly rising and falling, not by a lot, your urinary system is constantly offloading extra hydrogen ion to maintain that nice 7.4 level. So you have foods that will add acid or basic substances to the blood, amino acids, things of that nature. Metabolism will create acids and bases depending on which metabolic pathway you're looking at. And so you can regulate your blood pH, your physiological pH, by a couple of methods, right? So for instance, we have already seen the kidney approach, basically dumping hydrogen ion into the filtrate by swapping it out with the sodium, right? That's one way of doing it. We've already talked about the respiratory system, right? Where essentially you back up that carbonate buffer system and you just breathe out the CO2. That will also reduce it as well. You also have some acid-base buffer systems. Like for instance, you can actually neutralize it by adding different types of basic molecules to the hydrogen. And so there's a couple of different ways you can regulate it. We typically are using all three, right? So basically when you take a look at the buffer strategy, what the buffer does is it's going to mop up extra hydrogen ion or extra hydroxide ion that happens to be hanging around. And so our buffer system is the carbonate buffer system. We saw that one already, right? So this is basically it. So essentially when hydrogen ion enters the bloodstream, then what's going to happen is it's going to get mopped up by the bicarbonate ion, which is this guy right here. And it's going to create carbonic acid. Now, carbonic acid itself is not acidic. It's only when it falls apart into hydrogen ion that it becomes acidic, because it's the hydrogen ion that creates the acidity, right? So if you're able to move it in this direction, then that basically essentially takes that hydrogen ion out of commission. So that's one way to regulate it with the buffer. What happens if you dump an hydroxide in there? Well, if you drop a hydroxide ion in there, then what happens is this is going to get mopped up by the carbonic acid that we just created. And then what's going to happen is that's going to fall apart into bicarbonate ion and harmless water. So you can see you basically absorb that hydroxide ion, and it basically maintains the pH. That's basically what buffers do. Now, the respiratory center, we talked a little bit about this already in the respiratory system. So this is just kind of like a recapitulation of that idea. Is in this particular situation, say for instance, if you have an increase in hydrogen ion, what you can do is you can basically push this reaction in this direction, and you can breathe out the CO2, gets rid of the excess hydrogen ion by essentially breathing out the excess CO2. And that kind of keeps it from acidifying your blood. So that's one way to do it. And then of course, in the kidneys, we can take a hydrogen ion and we can pair it up with any number of more basic types of molecules. For instance, a common one is we take some ammonia and we basically use the ammonia to grab onto the hydrogen ion, and it turns into ammonium, which can be excreted as waste in the urine stream. So ammonia, remember we said that ammonia is one of those byproducts that you make when you're metabolizing amino acids. So when you take off that amino group, it oftentimes comes off as ammonia. And then when you add a hydrogen ion to that, it becomes ammonium, which is very soluble in water, easy to get rid of. And so you can easily dump that into your filtrate system, and then you can get rid of that. So you get rid of two things. Actually, this is kind of cool, right? Because you basically get a twofer, right? Buy one, get one. For the price of one, you eliminate two molecules. You basically get rid of one nitrogenous waste, ammonia, which is highly toxic to us, right? And you also get rid of a hydrogen ion in order to regulate your pH. And so all three of these are at work in pH regulation. So before, we've seen them before, right? But we've seen them before in isolation. Like, for instance, we saw the respiratory one just as a pure function of the respiratory system. This is the first time, actually, when we've seen all of these different mechanisms for pH adjustment all in the same place. So we're taking all these different mechanisms and we're putting them all together. So ultimately, as a capillary is kind of going by, if you have excess pH, what's going to happen is you're going to offload that pH into, that's secretion, right? Into the filtrate, where it's going to combine with ammonia to become ammonium, right? And then your bicarbonate, which is also in there, will basically balance it out by coming back into the bloodstream. So you kind of like get both of them happening at the same time. So you're balancing that charge, because remember, bicarbonate ion is negatively charged, hydrogen ion is positively charged. So you're kind of balancing that out to make sure that you don't get an imbalance in that particular situation. So there's some other things that kidneys do. This feels like this functional list never ends, right? The kidneys are doing a lot. Believe it or not, the liver does more. The kidneys are doing a lot, but they also help with other things. For instance, they will also secrete erythropoietin, and erythropoietin, remember, is associated with production of red blood cells in the red bone marrow. It will also do the vitamin D thing, so it basically secretes calcitriol as a vitamin D, which allows you to be able to absorb calcium from your digestive system. And it can also regulate the electrolyte secretion, like, for instance, of calcium, to make sure you're not losing lots of calcium. And so calcium typically we think of as sort of a major ion associated with bone density, because the calcium is part of a molecule that will actually make your bones hard. It'll actually harden your bones. And then it's also necessary for muscle contraction. Without calcium, you have no muscle contraction whatsoever. Okay, so those are really, really important ions, and the kidney is kind of right there in the middle of it all. It'll also regulate, of course, sodium and potassium in the blood. These are also necessary for nerve conduction. So when you take a look at nerve conduction, sodium and potassium are key in actually the nerve being able to send a nervous impulse from one place to another. And of course, without nervous impulses, you don't have the actual message going to the muscles to contract, which also need calcium to contract. So a muscle contraction, including your heart, requires three ions, at least three ions, to be able to function. It requires sodium and potassium as part of the neural signal to tell the muscle to contract in the first place. And it also needs calcium as part of its contraction mechanism. So the kidneys are actually involved in all three. So that's a big, long functional list, isn't it? There's a lot. The kidneys do a lot. This is one of the reasons why your kidneys are an enormously important structure, right? And why kidney failure is typically something that you don't want to see happening. And so having different types of urinary system disorders typically will cause a lot of problems. For instance, there's a lot of different types of disorders you can see, anything from just mild sorts of things like hypertension to complete failure. But you never want a kidney system that's not functional. You want it to be good and functioning and to function well and properly. So one thing that you'll see is urethritis. So itis basically means infection of a particular structure. In this case, it's the infection of the urethra. And so that's one situation. Cystitis is an infection usually of the urinary bladder. So they're basically calling the urinary bladder a cyst, which is just basically an open cavity. That's basically what a cyst is. Pyelonephritis is the infection of the entire kidney. This is really not a good situation. You don't want your entire kidney to be infected. That's really, really bad news. You also have various types of urinary tract infections, where you essentially have bacterial infections in one place or another, usually in the urethra, oftentimes. In males, you'll have enlarged prostate glands, which can cause problems. You have pH imbalances, kidney stones, which basically means you have too much calcium. So if you have too much calcium, it starts to precipitate out. And when it precipitates out, it starts to form little granulations that get bigger and then bigger and then bigger and then bigger into these large kidney stones. And those kidney stones can occlude the normal passage of the urine. And they hurt. So these granules of calcium and phosphates and uric acids and proteins, they can form. They're typically in a urine sample, there is a certain amount of aggregation that's normal. So just because you have some crystals forming in your urine does not necessarily mean that you need to hit the panic button. There is a normal amount of that. It's just when it starts to become extreme that it becomes a problem. Now, usually if it's in the renal pelvis, you don't really feel it at all. And that's usually because the urine can flow around it and things like that. But if they're typically large, they can block the pelvis, the entry to the pelvis, and they can block the ureter. And so this will basically block the actual passage of urine, and it can actually start to build up and back up and start to destroy nephrons, which is one of the reasons why stone development is problematic and can be quite painful as it kind of works its way through the system. So typically, if you have a stone that's kind of getting stuck in the ureter, but it's kind of moving, and you basically go through a passage where you're kind of talking about passing your stone. What that basically means is it's going from one place to another. So once it kind of works its way through the ureter, it's going to be painful while it's in there. But then once it enters into the bladder, it's got an open space, and then oftentimes you don't feel it anymore until, from there it could either break up, or it could just hang out, or it'll move into the urethra, and then you'll start to feel it again. And so that'll be a little bit of a different pain. Typically, when you take a look at nephron damage, and this is really bad news, right? Remember, this is the key structure in your kidneys. You do not want to damage your nephrons. You damage your nephrons, you damage the ability to function normally according to all that long functional list that we have, right? So basically cleaning up your blood, generating filtrate, generating urine, water salt balance, acid base balance. So all of those functions that we had are going to be compromised if you start damaging the nephrons. And nephrons are the functional unit of the kidney. If you damage these, you're in deep trouble. So what are some of the first signs? Number one is you start to see abnormal accumulations of things in your urine that shouldn't be there. For instance, albumin. This is one of those large plasma proteins. It shouldn't get through the filtration membrane. So that shouldn't even make it into the filtrate. That should be going out the efferent. White blood cells, also supposed to be too large. Red blood cells, also supposed to be too large. If you get all the big stuff, these are the non-filterables, by the way, if you're keeping track. These are supposed to be the non-filterables, the ones that stay behind in the blood and exit out the efferent arterial and go back into the blood system. If you've got these accumulating in your filtrate and in your urine, what that suggests is that you've basically blown gigantic holes in your filtration membrane. Your nephron is fundamentally broken. It's damaged. It's kind of like taking a filter and ripping a hole in it, right? All the big stuff is going to start coming through. And that's one of the reasons why we oftentimes will do a urinalysis. A urinalysis for a lot of, especially primary care levels, is pretty reflexive, right? And so the idea of a urinalysis is it's designed to basically catch potential abnormalities. Now, it's not necessarily diagnostic. Nobody's going to do a diagnosis based on urine, unless, of course, it's maybe glucose, right? If you got a high glucose level, you could probably do a pretty safe diagnosis there of diabetes. But for the most part, most of the time, what the urine is telling you is that there's something that's out of balance here, and that it's worth basically going after a blood test to get a deeper, more accurate number of what's actually happening. And so it's just kind of like a tip off to the doctors that there's something out of balance, and that they might want to basically order some sort of a blood test. Now, uremia, we talked a little bit about this before earlier in the chapter, is the accumulation of urea and other stuff, nitrogenous bases or nitrogenous compounds mostly, that starts to back up in the blood. And so this is only going to happen when the kidney damage is pretty severe. So as you start to get the accumulation of urea and other wastes like ammonia, for instance, this is usually a bad idea. It's basically backing up in the blood itself. So this is basically a sign of pretty severe kidney failure. Now, normally, your kidneys are pretty scrappy. They can function on pretty low levels, but if you have north of 2/3 of your nephrons that have been obliterated or damaged, then this is probably where you're going to start to get to uremia. Uremia, oftentimes because of the accumulation of metabolic waste in the bloodstream, will oftentimes start to give patients a bit of a smell. I can't really describe it. It's got a very distinct musk associated with kidney failure. That's because the buildup of all these nitrogenous waste in the bloodstream. The buildup of ammonia in particular is something that can cause a lot of problems for the overall body. Like, for instance, some of these buildup of some of these nitrogenous waste can cause things like edema. So it can cause swelling where you have fluid accumulation in the body tissues. It can also lead to hallucination. So they can actually start to affect the brain, and it can cause hallucination of individuals who have a huge amount of this in their bloodstream. So it's not uncommon when you see people in sort of like late stages of kidney failure. Oftentimes, it's combined with liver failure. You'll oftentimes see the two of those go down together. The liver will go down. It'll kind of drag the kidneys down, and then you'll start to get this kind of strange sort of hallucination phenomenon. And usually once you get to that particular point, you're pretty close to the end at that particular juncture. And so this could lead to loss of consciousness because of its activity and its effect on the brain itself. And ultimately, it'll take your heart down. So the important thing is your cardiovascular system oftentimes is the strongest system in your body. Not always, but often. So if your liver starts to go down, it'll drag down the kidneys. And then as the liver and the kidneys start coming down, it'll start to weigh heavily on the cardiovascular system. And your cardiovascular system will just fight and fight and fight and fight until the weight of the organ failure just becomes too great to where it finally succumbs. And that's something you kind of see a lot of times when you start to see generalized organ failure. Now, hemodialysis, this is basically treatment for it. So essentially you can have an artificial kidney machine where you have CAPD, continuous ambulatory peritoneal dialysis, essentially where you're taking fluids and you're pushing it through your peritoneal liner as a way to sort of filter out the fluids. And so with dialysis itself, what's happening is you're basically taking, you're diffusing out these dissolved molecules with this sort of semi-permeable membrane. It's a pore size associated type of situation where only small molecules can pass through. So you're filtering it basically, is what you're doing. And so that's one way to do it. A kidney machine essentially is going to be taking the patient's blood. It's going to pass it through the machine, a membranous tube, basically. And then it's going to be in contact with a dialysis solution called the dialysate. And then that's going to allow you to sort of transfer or to dialyze the fluids. And so you kind of like pull some of the waste out and you add a little bit of the fluids back in, and then that can go back into the patient itself. Generally speaking, more concentrated things like waste and stuff like that will diffuse into the dialysate because it's usually more dilute than the others. And so And the other way around, if it's more concentrated in the dialysate, then it'll go back into the blood. So basically what you're trying to do is you're trying to mimic with this, you're trying to mimic reabsorption and secretion, but you're kind of doing it osmotically, right? By playing this osmotic game. So a couple of things with an artificial kidney, you can basically use this to pull stuff out of the blood by just kind of manipulating the dialysate, the nature of the dialysate. So you can suck out waste products. You can also suck out toxins or drugs, things like that. So if you're trying to clear a particular dangerous drug, you can actually put somebody on dialysis and suck out the toxin or the drug to get their body to clear it faster. If it's having that'd be kind of more like an emergency approach, right? We got to get this drug out of him now. We can't wait for his kidneys to clear this drug because it's going to kill him before his kidneys clear this drug. So we want to basically clear this drug out. You can basically do this if you needed to suck that out. Normally, hemodialysis will take around 3 to 6 hours, so twice a week. Right? So a dialysis patient oftentimes is making a routine visit to their dialysis center, and they're going to be there for a while. So if you think about it, that's a pretty big chunk of your day. 3 to 6 hours, basically twice a week, 2 days out of your week. That's what your day's about, is going and doing dialysis. But if you've got kidney failure, this is the thing that's keeping you alive. So, hey, I can sacrifice 2 days a week if it keeps me alive a little bit longer, right? Now, the peritoneal dialysis membrane is a little bit different. So in this particular case, you take your dialysate and you introduce it directly into your abdominal cavity, and you essentially force that through the peritoneal liner. That becomes your filter, essentially. So all the waste and the salt molecules and things like that will move from the blood vessels, and then it'll go into the dialysate. So the blood vessels that are in the abdominal wall, that's the ones you're going after. So instead of doing it in the kidney, what you're doing is you're accessing the blood vessels in other areas of the body. And you're using your dialysate to essentially sort of suck out all of the waste and the salts and things like that. And then you'll recollect that fluid that basically picked that all up. Now, the good thing about this one, as opposed to the machine, is that normally you can just kind of go about your normal activities during the CAPD, because what's happening is you're basically filtering the fluids in there, and the fluids are doing all the work, not the machine. So your body's kind of doing it. And there are some people, run into some people who have this particular strategy. They're doing a peritoneal dialysis as opposed to a kidney machine. Ultimately, then, worst comes to worst, you can always replace the kidney. And so you can do a kidney transplant. But however, with all transplants, you always have to make sure that you're aware of organ rejection. And so generally speaking, when you take a look at an organ transplant, especially for the kidneys, oftentimes your 1-year survival rate is pretty good, 97%, right? If it's received by a relative, if it's 90%, then it's a non-relative, right? So essentially you have a better survival rate if you get it from a near relative. Less rejection, basically, is what's causing that. So you're less likely to reject a relative's kidney as opposed to a stranger's kidney. But still, 90% success is actually not bad, especially since you're basically dancing with and you're looking at total kidney failure as your alternative. Okay, that's urinary system. So the exam will cover up to and including urinary system. So everything from here on out is going to be on the last exam, because the next chapter that we're covering is going to be the nervous system, which is chapter 14. Okay. I think I have here somewhere. That one might already be written on. Let me see if I can fetch this from our course page. So if you're wondering where 12 and 13 are, those are skeletal and muscle. Those are the ones I'm going to be setting up on Connect for you guys to do. And I also have, I'll be loading as well some PowerPoints for those two chapters, some recorded lectures for those particular two chapters. Okay, so nervous system. So there's a lot going on in the nervous system. It's a huge, huge chapter. And so, but there's a lot of pieces to the nervous system. So we'll take a look at this one. So when we take a look at the nervous system, we can break it up into two basic halves. So essentially the purpose of the nervous system is as a regulatory system. Its job is to take in sensory information from the outside world, both external and internal. So not just the environment outside, but the environment inside your body as well. And then it will send out communications to the body. So it's a coordinator. So this is a big coordination system. And there's two major divisions. We can break it up into the central nervous system and the peripheral nervous system. So the central nervous system typically is the brain and the spinal cord, and the peripheral nervous system is everything outside of that, right? So the nerves in your body, the ones that you typically injure when you cut your finger or something like that. So here is your central nervous system. You can see you have your brain, your spinal cord, and the cranial nerves. So that's kind of part of your central nervous system. And when you take a look at your nervous system, basically you have the two different pieces kind of working together. So you have your brain and your spinal cord basically sending communications back and forth to each other. And then they're also sending communications out to the body. And so this is basically kind of moving away from the brain and the spinal cord. And then you have an area where you basically have information coming in toward the brain. So if you want to start from kind of a place where we normally think of, let's take a look at our environment, right? So in our skin, in our body are all types of receptors. And these receptors are designed to essentially collect data associated with our external environment. For instance, in just our hands, we have touch receptors, we have pressure receptors, we have heat and cold receptors, we have pain receptors. We have all kinds of receptors that are designed to allow you to gather information associated with the outside world. And that's the sensory side of things. So the sensory side of things is basically always coming from the outside and moving up to the brain. For instance, you'll have what's called somatic sensory signals. This is coming from your skin and your muscles, things like that. information you're collecting from the outside world. And you also have visceral sensors, which essentially are getting signals from inside your body, right? So basically these sort of homeostatic cues that are happening inside your body. A good example of that is like we just got done talking about it, right? So acid-base balance. So how does your body know when your acid is getting too acidic, right? When it's getting to, when it's moving toward acidosis? There has to be some sort of a structure that's designed to sense or to measure when your blood pH is getting too low, when it's becoming too acidic. And that's basically, you have a bunch of receptors out there that's monitoring those sorts of internal visceral types of conditions. All that sensory information is basically going to be moving up through the sensory pathway, through different nerves, typically going up to the brain and the spinal cord. We call these afferent nerves, afferent for arrival. It's arriving to the brain itself. All that information is going to come to the brain, and the brain's got to sort all it out. So it's got to basically sort all this information out and make sense of it all, figure out what type of response it wants to make, right? So it's kind of like what you do when you make a decision. If you have a difficult problem that you need to make a decision about, what do? You gather information, right? You gather as much information as you can. And then once you get all this information, then you kind of sort through all that information and try to figure out what your best response is based on what you want to achieve. And that's what the brain is doing. And so what it's going to do is it's going to send that response to the spinal cord. And then from the spinal cord, it'll move down through what's called the efferent pathways. E for exit, it's exiting the central nervous system. And it's going to be moving through the motor area. These are the response areas. And it's going to be going in, splitting into two different halves. The first one is going to be what's called somatic motor. So these are basically signals that will essentially communicate with skeletal muscles, telling the muscles to contract, right? So that's basically a contraction signal. Move your arm, right? That's basically what that signal is. But another group of these outputs will move into what's called autonomic motor. So these are nerve signals that are essentially these sort of visceral cues. They tend to be involuntary. So a good example, your blood pH starts to move into 7.30. We just saw a couple of slides ago on the pH balance of the urinary system that is going to be moving into acidosis, right? So that pH level is going to be sensed by a sensory receptor, moved up the sensory pathway to the brain. The brain is then going to come up with an appropriate response. In this particular case, maybe the response is for you to use your antiporter to swap out a hydrogen ion for a sodium, dump the hydrogen ion into your urine stream. That's your response, right? So that is all visceral, involuntary. You don't have to think about any of that. Why? Because your body is constantly automatic. It's on autopilot. It's constantly automatically adjusting itself, maintaining homeostasis. And so these outward paths that are unconscious and involuntary can be broken into two different pathways. One's called the sympathetic division or the fight or flight division. This is your stress response. The other one is the parasympathetic division, which is the rest and digest. This is your rest response. So for instance, in my case, I'm at rest. There's no lion in the room, so I'm not stressed out, right? So what's going to happen is my pH adjustment response is going to go to the parasympathetic. It's going to tell my kidneys to offload a hydrogen ion into the urine stream so I can get rid of it, bring my pH back to 7.4. Right? So you constantly have this circulation between sensory information constantly coming in and your central nervous system constantly sorting through it all, coming up with some sort of a decision before it sends out the appropriate signal. And that's basically how your nervous system works in a very generalized sort of a way. So for the most part, you have three major functions. We already talked about sensory information. So that's one of them, right? So essentially you have sensory receptors spread out throughout your body, bringing in information and intelligence from everywhere in your body. Then you're going to have integration. So once you actually get all those inputs, all that intelligence, you're going to have to basically do something with this. So you're going to have to create a motor response or some sort of an appropriate response based on that information that you've collected. It's also going to be associated with storing up memories, right? So you can actually train your immune system, your nervous system, to basically have an integrated sort of a pathway. And then, of course, it's going to have a motor component, right? So this is basically an outgoing motor response that generally will target either muscles, glands, or organs to do something. This is an effector. Now, when you take a look at nervous tissue, and this is kind of a recapitulation from our tissues chapter, so I want to build on that. You have two major types of cells, right? So you have neurons and you have neuroglia, oftentimes referred to as glial cells. So the neuron's job is to transmit nerve impulses. This is the conductive tissue. The neuroglia are basically the support team for the neurons. Now, generally, there's a lot more neuroglia than neurons. There's a lot more in the entourage than, say, for instance, the star. There's one star, and there's an entire spectrum of support casts around that star. Now, the different types of neuroglia that you're going to see in the central nervous system are what's called microglia, astrocytes, and oligodendrocytes. And in the peripheral nervous system, you see Schwann cells. And what we're going to do is we're going to take a look at what each one of these is doing. When you take a look at the central nervous system, the microglia, which is our first stop, basically the microglia represent a group of cells that are phagocytic cells. So this is kind of like an immune support for the central nervous system. So its job is to remove bacteria and kill off bacteria, gobble it up and destroy it. Also to clean up any debris associated with injury or things of that nature. The astrocytes are a little bit different. So these are kind of like nurse cells. So what the astrocytes do is basically they provide both structural support and metabolic nutrition to the neurons itself. Think of the astrocytes as sort of like mother cells, kind of like a mother is to a baby, right? So a neuron, for instance, is the baby. Pretty helpless, but really good at what it does. In this case, the baby is good at being cute, right? But who gets to feed the baby? Does the baby feed itself? No. Nutrition to the baby comes by way of mom. Matter of fact, everything the baby needs comes by way of mom. And so the same thing is true for the astrocytes. Everything that the neuron needs comes by way of the astrocytes, including nutrition. The oligodendrocytes basically will form what's called a myelin sheath, which is kind of like insulation around a copper wire. I'll explain that when we get deeper into the myelin sheath discussion. Okay. And this is going to be in the central nervous system. The Schwann cells then are going to be similar to the oligodendrocytes. They form myelin sheaths, but in this case, it's for the peripheral nervous system. So the oligodendrocytes provide that sort of insulation for the neurons in the central nervous system, and the Schwann cells provide that insulation for the neurons in the peripheral nervous system. So this is a really, really good place to start next time, is the anatomy of a neuron, because we're going to basically kind of break down a lot of the anatomy, the structure of the neuron, the nervous system, and then we're going to start integration and regulation. Okay, so that is the day.